So my presentation is on cervical degenerative disease. It is a fairly lengthy presentation. In order for us to understand the whole concept of cervical degenerative disease, we have to first understand the definition of what cervical spondylosis is. Prevalence of cervical degenerative disease is very high. Typically affects person in their middle age. The level involved is mostly C5-6 followed by C6-7. Men are more affected than women. The risk factors include frequent lifting, smoking, and interestingly, history of excessive driving. This is also correlated in degenerative disc disease of lumbar spine as well. It begins with the degeneration of the intervertebral disc, which then will subsequently result in loss of disc height, weakening of the annulus fibrosus. That leads to somewhat of a redundancy on the annulus. That leads to a transfer of the load and increased stress on the facet joints. That will further lead to what I consider microscopic instability, leading to hypertrophy and formation of osteophytes and thickening of the ligamentum flavum. This is a cartoon depiction of a cervical spondylosis. You can see the formation of disc osteophyte resulting in foraminostenosis here. This is a demonstration of a soft disc herniation pressing on the spinal cord as well as the takeoff of the nerve root. This is evidence of a facet hypertrophy causing nerve impingement as well. So cervical degenerative disease can lead to multiple symptoms that can include just purely what you consider axial neck pain, or a combination of neck pain along with radiculopathy, myelopathy, or combination of neck pain and radiculomyelopathy. Let's first talk about the axial neck pain, its presenting symptoms. Typically, the pain is localized to the posterior aspect of the cervical spine. The person will often complain of occipital headache, stiffness, and spasm. There's absence of any radicular type of complaints. Evaluation of patients with axial neck pain includes plain radiographs, advanced imaging such as MRI studies as well as CAT scan studies. Rarely a provocative imaging study such as discogram are utilized, and sometimes a diagnostic injection under fluoroscopic guidance can also be helpful in evaluating patients with axial neck pain. X-ray is indicated in a person with history of trauma, prolonged duration of symptoms, or if someone has known systemic disease such as cancer or inflammatory arthritis, or if the person is presenting with constitutional symptoms such as fever, chill, weight loss. AP view is important in assessing the presence of spondylosis. This sharp corner here depicted on the AP view is called joint Zalushka or oncovertebral joint. And in patients with spondylosis, you will see rounding of this area. Lateral view gives us overall assessment of the alignment, status of the discs, absence or presence of osteophytes, or instabilities. Oblique views, although not obtained frequently, can best visualize the status of the neuroforamens. Flexion extension views are important if there's a history of trauma or history of inflammatory arthropathies. Open mouth view is helpful in a trauma setting to rule out any kind of upper C-spine fractures. Also, it is helpful in detecting presence of atlantoaxial arthritic conditions, which is seen on this X-ray to the right. Advanced imaging studies include MRI studies as well as CAT scan studies. CAT scan study is great for delineating bony anatomy. Fractures are best visualized on the CAT scan studies. It can also show facet arthritis, absence or presence of foramintosis. Sometimes on the MRI, it's difficult to ascertain whether this protrusion that is seen represents a soft disc versus a hard disc, and CAT scan correlation with CAT scan can often confirm presence or absence of any bony osteophytes. And obviously, OPLL is best visualized on CAT scan. CT myelogram is very useful, especially in patients that are contraindicated to undergo MRI studies. So we reserve this study for patients with contraindication to MRIs. Nowadays, there are many manufacturers with MRI compatible pacemakers or spinal cord stimulators. So those patients nowadays can safely undergo MRI studies. There are certainly other contraindications to MRI, such as metal fragment in the spine or in the brain. MRI study is, I would say, the gold standard. It is great for assessing the soft tissue details. However, one has to be cognizant of the fact that there are high prevalence of degenerative disc disease present in a normal asymptomatic population, and that the radiographic imaging only confirms one's clinical diagnosis. Differential diagnosis of axial neck pain includes fracture, dislocations, inflammatory arthropathies, possibility of infection tumors, and one can never rule out fibromyalgia, as well as someone presenting with a secondary gain, especially following a work-related injury or a motor vehicle accident. Treatment for axial neck pain is fairly straightforward. It includes use of anti-inflammatory medications, physical therapy, and in severe or in chronic cases, pain management specialists can utilize multiple injection techniques. I want to talk about atlantoaxial osteoarthritis. I feel that it is often an overlooked cause of axial neck pain, especially in an elderly population. The pain is very typical. It is localized to occipital-cervical junction region. Patients will often complain of pain that radiates into the back of the head. The pain is often accentuated with lateral rotation of the head. In terms of surgical consideration for axial neck pain, the answer is almost none, with exception of C1, C2 fusion for severe C1, C2 osteoarthritis. Radiculopathy is probably one of the most common presenting symptoms of cervical degenerative disease. Patients with radiculopathy often presents with pain in a very specific dermatomal distribution. There are at times associated weakness with the myotome. Reflex changes are often noted. It is important to remember this slide, as this is what I consider a gimme, where you just have to remember this, that in cervical disc disease, the nerve root that is affected is above their corresponding vertebrae. So for example, C5-6 disc herniation will typically involve C6 nerve root, whereas typically in lumbar spine, let's say for example L4-5 posterolateral disc herniation, the nerve root involved will be L5, not 4. You should also remember that there is no C8, therefore disc herniation at C7-T1 will involve C8 nerve root. Unfortunately, you're just going to have to remember this table, as questions can come up in various different scenarios, testing you on the nerve roots in terms of the motor and the sensory as well as the reflex involved. Cervical radiculopathy can occur from a soft disc herniation, or in chronic cases from hard disc ossified complex, or it could be certainly a acute soft disc herniation superimposed on hard existing disc ossified complex. The way the pain is reproduced, however, is a little bit different. In soft disc herniation, there is a component of mechanical as well as a chemical irritation, whereas in hard disc, or in cases of chronic radiculopathy, the pain is mostly mechanical in nature. Physical examination of the patient with cervical radiculopathy includes performing Sperling test, which is demonstrated on the slide. Axial compression can also increase their pain. Shoulder abduction relief sign is depicted on the slide. It basically produces slack on the nerve root, therefore alleviating some of the radiating symptoms. And oftentimes you can stand behind the person and provide an axial traction, and in cases of acute cervical disc, the patient will report significant improvement with this maneuver. In working up patient with complaints of cervical radiculopathy, plain x-rays can give you a significant clue as to their etiology. However, again, as I previously indicated, the gold standard of imaging studies for cervical radiculopathy is MRI. It is the modality of choice. But there are times, not always, we will elicit or ask for additional diagnostic tests. These includes electrodiagnostic tests such as EMG or NCV tests, especially in someone with history of diabetes, or in older patients, or in someone where the symptom doesn't really match the MRI findings. It is important to rule out concurrent presence of peripheral neural compression. Differential diagnosis for radiculopathy is vast because of the fact that there's significant high percentage of abnormal findings on the MRI in otherwise asymptomatic patients. One has to always make sure that there are no other causes for the patient presenting complaints of radiculopathy. One diagnosis that I would emphasize is Parsonage-Turner syndrome, which is also acute brachial plexopathy. This can oftentimes present with a symptoms consistent with severe acute cervical radiculopathy. Most cervical radiculopathy resolve without surgery. They're oftentimes treated with a short course of physical therapy along with anti-inflammatory medications. Steroid, whether taken orally or given by epidural injection, can also be helpful. Surgical indication for cervical radiculopathy is in cases where there is a failure of conservative treatment. That includes persistent pain despite aggressive non-operative treatments, progressive weakness, or in someone presenting with profound weakness. Surgical options include anterior or posterior or combination. It depends on many factors, including the pathology, soft versus hard disc, location of the disc fragment, how many levels are involved, are there presence or absence of any axial neck pain, and one has to always pay attention to the presenting cervical alignment. Anterior approach is often performed transversely. It forms a cosmetically much more pleasing scar than the vertical. The anterior approach really involves minimal tissue disruption. Once the platysma layer is disrupted, there's really no cutting involved until you get to the prevertebral fascia. The choices for anterior cervical approach includes anterior cervical discectomy, which is really not performed in the States. There's also option of anterior cervical discectomy and fusion with or without instrumentation. So the answer of anterior cervical discectomy without fusion would be a wrong answer in our board examination. The reason for that is that it results in significant postoperative neck pain. Spontaneous fusions can occur in an unacceptable alignment. The short-term results tend to be okay, but it deteriorates over time as the disc will continue to settle. The disc space will continue to settle down, and you may get reformation of the foraminostenosis. However, it is still done in the other parts of the world, so it is an acceptable answer, but not in this country. Anterior cervical discectomy and fusion is probably the most common procedure that we do for cervical radiculopathy. It provides for direct decompression of nerve roots. It provides for neuroforaminal distraction. Fusion oftentimes results in resorption of the osteophytes, and in someone presenting with combination of neck pain along with radiculopathy, and that procedure can also result in relief of axial neck. The outcome is very favorable. The results are the best in single level. Pseudoarthrosis rate goes up as you perform more than one level. However, many studies have shown that there's no clear correlation between pseudoarthrosis and clinical poor outcome. But as you could imagine, if there's an obvious pseudoarthrosis, that person is not going to do well clinically. So the anterior cervical discectomy and fusion construct, you don't want to put a small graft in there because that is often associated with pseudoarthrosis. Question of allograft versus autograft. Autograft incorporates faster than the allograft, but overall fusion rate tends to be similar. Addition of plate results in higher rate of fusion, especially in multi-level. It can also protect the graft material in cases of corpectomy where the construct may be unstable. Leads to negating use of collar in certain patients, and it is often noted that the overall result of the fusion will lead to less incidence of kyphosis. Complications following anterior cervical discectomy and fusion is rare. Most common complication is dysphagia. I'm not so sure if pseudoarthrosis is considered a complication, but pseudoarthrosis can happen. Hardware failure is uncommon, but it can also happen. And also they like to ask questions on nerve injuries as well as injury to the thoracic duct, which is more common with left side approach. Hypoglossal nerve is anterior to the C2-3 disc space, so that is at risk when you're doing upper cervical ACDF. And the way you would diagnose the injury to the hypoglossal nerve is that the tongue deviates to the injured side of the nerve. Superior laryngeal nerve is anterior to the C3-4, but more commonly C4-5 disc space, so this can be also asked as well. The symptoms arising from superior laryngeal nerve is not as obvious as recurrent laryngeal nerve, as it may manifest with mild hoarseness of the voice with decreased vocal stamina. The one that they love to ask is the recurrent laryngeal nerve paralysis. It's thought to be safer with left-sided approach, as the nerve is longer, meaning the coursing of the nerve on the left side is much longer than the right. It is thought to be a combination of ischemic and direct injury to the nerve. Luckily, most of these injuries tend to be transient. And when revising someone with history of prior anterior cervical discectomy and fusion, it is pertinent, paramount that person get a preoperative ENT consult to look at the vocal cord, and if there's a suspected injury to the recurrent laryngeal nerve, then the revision surgery should be performed on the same side as if you perform this revision surgery on the other side and knock out the other recurrent laryngeal nerve on the contralateral side. That will be a disaster. One of the devastating complications that could happen from anterior cervical discectomy approach is Horner syndrome, manifested by ptosis, meiosis, which is overconstriction of the pupil, and anhidrosis. And it is caused by injury to the sympathetic chain that resides along the lateral border of the longus colli around C6 level. So you don't want to be going too crazy with the Bowlby cautery when you're exposing the longus colli muscle, as that could injure the sympathetic chain. So the long-term problem with the anterior cervical discectomy and fusion is that it alters the local mechanics of the cervical spine. It adds stress to the adjacent level, leading to increased risk of degenerative disc disease at the adjacent level at the rate of 1% per year. Incidence of radiculopathy, and it is often quoted that there's 25% re-op rate as in patients with history of anterior cervical discectomy and fusion in about 10 years. In order to counteract this altered biomechanics and to decrease the chance of developing adjacent level disc disease, disc arthroplasty was invented. The indication for the disc arthroplasty is similar to that of anterior cervical discectomy and fusion, and the result of the disc arthroplasty has been very favorable, especially in two-level cases when compared to the two-level anterior cervical discectomy and fusion in almost all outcome parameters. Posterior foraminotomy is at times indicated in rare cases of soft disc herniations that's positioned laterally. in cases of isolated foraminosis, or in a person with the difficulty with anterior exposure, someone with a really a thick neck with disc herniation at the lower cervical segment would be a typical approach. However, this leads the posterior cervical foraminotomy has high incidence of residual neck pain, so it is not considered a great surgical procedure when there's a significant component of neck pain along with the radiculopathy. This is the cartoon depiction of how the cervical foraminotomy is done. Complication of the posterior foraminotomy includes wrong level surgery. It can be done especially in the lower cervical level where the levels are not well visualized due to the shoulder superimposed on the cervical spine on the x-rays. There's much higher rate of infection, higher rate of nerve root injuries, and also very high rate of inadequate decompression. However, if the decompression is also too adequate or overperformed excessively, that could lead to instability as well. Cervical degenerative disease can also result in cervical myelopathy. Myelopathy describes a constellation of symptoms and signs arising from cervical cord compressions. Symptoms include hand clumsiness, difficulty with fine motor control, gait imbalance, and etc. It is the most common spinal cord dysfunction in older population. It is underdiagnosed and undertreated, as many of these patients are older and have other mobility issues. Key to diagnosis is careful history and careful neuroexamination, looking for presence of subtle gait disturbance or reflex changes, and one must have a high index of suspicion. Natural history of myelopathy is typically one of stable periods punctuated by unpredictable stepwise progression. The myelopathy occurs as a result of continuum of degenerative process. The disc degenerates, it leads to settling of the disc space with bulging of the annulus, herniation of the annulus and the other materials, that again leading to microinstability, and the body's attempt to stabilize this by forming osteophytes and hypertrophy of the facets and the ligaments, that resulting in further encroachment of the space available for the cord within the canal. This is the depiction of what happens in the canal as the spondylosis or the degeneration occurs. Myelopathy can result from direct mechanical compression of the cord itself, or there's also a vascular etiology where anterior spinal artery can be compressed from the anterior offending structures such as OPLL or disc herniation, and oftentimes the pathophysiology can be combination of both mechanical and vascular origin. There's also dynamic and static factors. If there's a significant instability, one can have dynamic myelopathic symptoms superimposed on static factors such as congenitally small canal, presence of osteophytes, disc herniations, ligamentum hypertrophy, and uncovertebral joint hypertrophy. Dynamic factors, again, can be reproduced by redundancy in the annulus as the disc space settles. This can lead to retrosthesis or anterolisthesis. Hyperextension can cause the buckling of the ligamentum flabum, in combination with anterior compression could result in pincer-like compression of the spinal cord. So the symptoms from cervical myelopathy depend on the multiple factors. Is the degree of the stenosis or the cord compression, whether the compression was acute in nature or chronic, and the constancy of the compressive force, meaning if the stenosis or the compressive force develop slowly, then the spinal cord is able to tolerate this much better than the compression that is acute, such as, let's say, for example, traumatic disc herniations. So patients with chronic progressive stenosis can oftentimes present with no symptoms, whereas someone with acute soft disc herniation with severe cord compression can present with severe symptoms of myelopathy, although the overall degree of stenosis in both cases may be the same. Clinical presenting symptoms of myelopathy includes in upper extremity generalized feeling of clumsiness of the arms and hands and dropping things and inability to button one's own shirt, trouble with handwriting. They will often talk about inability to sign their name on a check. They also complain diffuse numbness. In the lower extremities, they may complain of walking difficulties, gait instability. They report a sense of imbalance, and many times they'll tell you they keep bumping into walls when they're walking. They also complain of what you call limit signs or phenomena, where they complain of electric-like sensation that radiates down the body or the spine and the extremities with hyperextension or hyperflexion or repetitive flexion and extension of the neck. When examining these patients, oftentimes the upper motor neuron findings are not present, especially if someone has significant peripheral nerve disease or diabetes. You could have a combination of upper and lower motor neuron findings. Some of the physical examination maneuvers include Hoffman's test. You hyperextend the middle finger and basically flick the tip of the middle finger, and you look for flexion of the thumb as well as the index finger in response, and that would be considered positive Hoffman response. Inverted radial reflex may be also present. Klomas and Babinski's also suggested a presence of upper motor neuron symptoms, and the finger escape sign is sometimes asked. Sensory changes also, it may include changes in pain, temperature, and light touch perception. There can be also involvement of dorsal column with changes in the position and vibratory senses. Sensory examination is at times difficult to interpret, as the compression can occur at the multiple regions of the spinal cord. Differential diagnosis of cervical myelopathy includes multiple sclerosis, ALS, as well as anything that could certainly change the anatomy of the spinal cord, both intrinsically or extrinsically. Imaging and evaluation of this cervical myelopathy includes plain X-rays, MRI studies, as well as other studies including CAT scan or CAT scan with myelogram. Plain X-rays, again, you want to look for presence of any spondylotic changes. You want to look for instabilities on flexion extension X-rays. MRI studies, again, the gold standard. It is excellent in evaluating the etiology of the cord compression, as well as the status of the cord itself, absence or presence of injury to the cord. You can also rule out other intrinsic or extrinsic etiology for myelopathy. CT myelography, again, indicating someone who cannot tolerate MRI or MRI in patients where the MRI is contraindicated. Again, CAT scan is superior to MRI in terms of assessing the bony anatomy. It can be helpful in diagnosing or confirming the diagnosis of OPLL. It is oftentimes very helpful in planning surgical approach, as presence of certain structural anatomy can dictate whether you're going to approach the spine anteriorly or posteriorly. Few words about ossification of posterior longitudinal ligament, also called OPLL. It is an ectopic and chondral ossification of the posterior longitudinal ligament, commonly seen in Asia, especially in Japanese population, but it is also seen outside of Asia. Certainly can cause progressive myelopathy, and there is a classification scheme that you should be familiar with when discussing OPLL. Cervical myelopathy is basically a surgical disease. However, there are instances where non-operative management is indicated. In patients with radiographic evidence of spinal cord compression, however, there's no signs or symptoms of myelopathy, then that person should be generally observed. However, even if someone is completely asymptomatic but have significant severe cord compression, then that person should be operated on, as that person is a very high risk for developing spinal cord injury with a minor accident. However, patients with minimal symptoms or no symptoms can be safely observed. Non-operative management includes conventional conservative treatment with physical therapy, use of anti-inflammatory medications. Manipulation with chiropractic care is contraindicated in patients with myelopathy. As I have previously indicated, cervical spondylotic myelopathy is progressive in nature and is considered a surgical disorder. Surgical management has been shown to improve functional outcomes, pain, and neurologic status, and is the treatment of choice. Early intervention before the permanent spinal cord injury occurs improves the prognosis. Indication for surgery includes clinical evidence of myelopathy with neurologic demonstration of cord compression, progression of neurologic deficits and functional impairment, failure of neurologic findings and symptoms improve with non-operative treatment, and radiographic findings of severe cord compression. This compression ratio and the diameter is obviously based off the MRI. Prognosis factors associated with good prognosis include short duration of myelopathy, higher level of function, few comorbid medical conditions, a patient with a younger age, degree of compression, lesser degree of compression at the time of surgery has better prognosis, and radiographically absence of any spinal cord edema or myelomalacia. Once you see myelomalacia, that means that there's probably gliosis or scarring on the cord, and oftentimes it has been some irreversible damage to the cord. Preoperative consideration includes the mobility of the spine, sagittal alignment, number of levels involved, anatomy of the canal, and the evaluation of the area of compression. And if also important to note whether the person had prior surgery to the cervical spine. Options include anterior, posterior, and combination. The approach is based on location of the compression, number of levels involved, and the sagittal alignment of the spine, and absence or presence of the stability of the spine, instability of the spine. Anterior cervical decompression and fusion is indicated in single to multi-level involvement. If someone's got a kyphotic alignment, then you need to go anteriorly to try to restore the normal alignment. Anterior cervical discectomy and fusion is indicated in the 1 to 2 levels in absence of any cord compression behind the body. Cervical corpectomy and fusion is indicated in the multi-levels and or in cases where there is significant compression behind the vertebral body. The advantage of the anterior approach is that it provides for direct decompression of the structures that is most commonly responsible for cord compression. That includes disc, spondylotic spurs, and OPLL. So for myelopathy arising from 1 or 2 disc spaces, or even up to 3, single level or 2-3 level ACDF or combination of ACDF with corpectomy is the treatment of choice for most patients. The advantages include direct decompression, correction of deformity, distraction of the disc space, and relief of axial pain. However, there are significant disadvantages to the anterior approach as well. It is not extensile. It is difficult to expose in more than 3 levels, although it can be done. There are significant risks involved with multi-level surgeries, including increased rate of injuries to the structures mentioned on this slide. There can also be graft complications, including dislodgement, and higher rate of pseudoarthrosis in multi-level cases. Posterior approach is indicated in someone with multi-level involvement. However, in order to contemplate posterior cervical approach, the prerequisite is that of acceptable preoperative cervical alignment, preferably lordotic cervical spine. Options include laminectomy, laminoplasty, and laminectomy and fusion. Posterior cervical laminectomy, as an orthopedic spine surgeon, I would have to say is not often done. The indications include multi-level spondylotic stenosis, someone with OPLL. However, this is contraindicated in presence of cervical kyphosis, as laminectomy and laminoplasty relies on the fact that after the laminectomy, the cord will drift posteriorly away from the stenotic spine. Therefore, if someone has preoperative cervical kyphosis, this laminectomy approach is contraindicated. Disadvantage of laminectomy includes potential for destabilization of the cervical spine with development of post-laminectomy kyphosis. Laminoplasty is often utilized in patients with OPLL or even diffuse multilevel cervical spondylotic myelopathy. Again, prerequisite for cervical laminoplasty is a cervical lordosis. Contraindications include preoperative instability, kyphosis of cervical spine, or if someone has a large soft disc herniation anteriorly, as the motion is preserved in laminoplasty, so there exists potential for the further herniation of that disc herniation, resulting in recompression of the cord. Laminoplasty's advantage is that although it is multi-level, it doesn't involve fusion, so your neck doesn't become as stiff as the laminectomy and fusion, and there's biomechanically less tendency for patient to develop instability when compared to laminectomy. Complications of laminoplasty includes C5 nerve palsy, which is often talked about, closing of the laminoplasty door, infection, and persistent neck pain. Late complications include kyphosis, residual radiculopathy, and stiffness. The advantage of laminectomy and fusion is that it is extensile. You could unzip someone from the head all the way down to the buttock with one incision, right? So the laminectomy and fusion is indicated when there's significant diffuse levels of compression, as it provides for complete access to the entire cervical spine. And also it is used if there's instability, as it prevents post-laminectomy kyphosis, and it helps to maintain the cervical lordosis with use of instrumentations. Contraindication for just performing laminectomy and fusion would be in someone with kyphotic spine that remains kyphotic with extension maneuvers, as even with the generous cervical laminectomy, that the cord in kyphotic spine may be draped anteriorly, which would result in persistent myelopathic symptoms. Complications of all posterior approach, whether it's laminectomy alone or laminectomy infusion, is that it has much higher rate of wound infection. Pseudoarthrosis can also occur, and laminectomy infusion actually has higher incidence of C5 palsy than the laminoplasty. Okay, so that ends my presentation. I have two more slides that I put together that kind of emphasizes what I would consider often repeated themes on the exams, particularly with respect to the radiculopathy and myelopathy. They love to ask indication questions. They also love to ask anatomy questions, right? So if you get these anatomy questions, then it's your fault because you didn't study. But you should also know some of the concepts, especially when they're asking about radiculopathy. As long as someone is not presenting a progressive neurologic deficit, I would always say the answer is non-surgical, right? So if they give you someone with progressive neurologic deficit, boom, game over. Surgery is the answer, right? However, this is different in cervical myelopathy. You should know that the cervical myelopathy is a surgical disorder. So as long as, unless they're very clear on the patient presenting with absolutely no evidence of myelopathy, answer for treatment for cervical myelopathy will always be surgical. 1 to 2 levels with otherwise 1 to 2 levels would be mostly anterior. Multiple level will be posterior. And again, be concerned about the absence or presence of cervical malalignment, as that would also dictate which way you would approach. Good luck. Thank you.